Okay, Bismillah. Let's start. Your first case can be fun. 50 years old male patient came with a refractory headache for 1 month.
Okay. Look, I couldn't find the scrolling bar. Okay.
Okay, don't worry about the scroll bar. Just use your arrows or track balls. Okay.
Okay. And I will the arrows. But okay, start.
Scroll
Okay.
slowly. Okay.
Okay. Okay, this is axial cut MRI brain for a patient coming with refractory headache for 1 month. I will have a look in the axial cut of this brain and then I will comment.
1 second, please. Just okay. Click once again and scroll.
Okay. This is axial cut T1. Just I will try to scroll and then I will comment. Okay. The
By the
patient.
way, you have only 5 minutes per case. Okay.
Okay. The patient coming with refractory headache. I'm trying to look for the abnormality and it appears this is the T1. I'm just trying to look if there is any abnormality noted. Okay. I couldn't appreciate until now. In the foramen magnum, it appears to be normal. I will have a look. I believe that there is abnormal hyperintense signal noted in the superior sagittal sinus, but I wanted to look for it in other sequences. I couldn't really appreciate any other abnormality in this T1. No abnormal hyperintense signal noted in the sulci.
Okay, what are the check areas in the MRI brain T1 you are looking for?
I'm trying to look for the superior sagittal sinus if there is any evidence of thrombosis. I'm trying to look.
Okay, no thrombosis.
Okay.
Any other abnormality?
I really couldn't appreciate. Maybe this is abnormal. This in the sulci, it appears to be hypointense, but this could be the blood vessels in it.
Signal voids of the blood vessels.
Yes.
Okay.
So, I'm trying to look for the bone window also. I'm trying to look for the bone in the T1.
Okay, what will you do next?
I wanted to look for flare or any other sequence for this patient.
Okay, here's the T2.
Okay. In the T2, just 1 second. I can appreciate that there is evidence of, just I will have a look and then I will comment. Okay. Sorry, it's jumping, but
Wait, scroll slowly. Don't scroll one time.
okay. I can appreciate that there is evidence of bilateral hyperintense, but this appears to be also bilateral collection in the
Where is
subject.
the location of this collection?
It extends through both cerebral hemispheres, frontal, parietal, and occipital. It appears to
Okay,
be
where is the location, exact location?
extra-axial, subdural.
Okay,
It appears to be hyperintense signal.
okay.
I'm trying to see if there is any other abnormality. Both ventricles appearing normal. There is no evidence of any other abnormality. Just I wanted to look for this. The patient coming with refractory headache. I wanted to look for the post-contrast.
Okay, what are you suspecting?
I'm suspecting this could be, as there is no constitutional symptoms or fever, so this is not pus or embyemia. I'm suspecting this could be subdural cystic hygroma, maybe associated with hypotension, intracranial hypotension. So I wanted to look if there is any evidence of pachymeningeal enhancement.
Okay, what are the other features of this case you are looking for, other than pachymeningeal enhancement?
Yes, I would look for the pituitary gland, and I would look also for the in the
What will be the abnormality in pituitary gland?
in the pituitary gland, there would be hyperemia or in it, and also I would see in the venous sinuses, it would be enlarged slightly compared to the normal. And also there would be in the sagittal view maybe sagging of the corpus callosum and the hernia. Okay.
Okay, scroll through the flare.
Okay. So it's scrolling. Yeah, started now. In the flare, it appears to be hyper intense again. Just I will have a look for the other. Okay. Okay, in the flare, it appears to be hyper intense signal. Hyper intense signal. It's not CSF signal. It appears to be hyper intense. So it could be also this could be a hematoma. I just wanted to look for the. Okay.
Okay, here is the post contrast.
Okay.
Give me your final diagnosis and management.
Okay. In the post contrast also, it show contrast enhancement. It's not okay. In the post contrast, it show pachymeningeal enhancement for the pachymeninges. So I believe that this is a case of intracranial hypotension. This intracranial hypotension would need we need to refer this patient for the neurology team for discussion and
What
management.
could be the causes of intracranial hypotension?
It could be leaking from the CSF, maybe from previous operation or from any.
Do you know the treatment of any CSF leak?
Sometimes in the CSF leak, they are using epidural blood patches to close the leak.
Okay. Just wait, I will adjust this. Okay. Chronic cough,
Okay,
30 years old.
frontal radiograph, mature skeletally patient for the chest. The patient coming with the chronic cough and, he is 30 years old. I can appreciate that there is evidence of bilateral reticulations scattered through both the lung parenchyma. These reticulations appear to involve more in both upper lung. However, it also involving in the left lower lung, more in the left rather than the right. These reticulations also appear to be slightly hyperdense, and it appears to be more central rather than peripheral. Yet I really couldn't appreciate decreasing in the lung volume in both the lung. However, there is evidence of fine blunting of right costophrenic angle, which may be a very tiny pleural effusion. Both apex, I couldn't really appreciate any abnormality in the mediastinum or in the bone. Or in the retrocardiac region. So, as a summary, this is
Anything else?
I am trying to look. Yes, there is evidence also of left side pneumothorax. I can appreciate it. This patient has with chronic cough and this appearance and this imaging finding, I'm thinking of maybe cystic lung disease affecting with rupture of these cysts and causing this pneumothorax. It could be also cystic fibrosis, mainly because it affecting both of upper lung and this heavy opacity that's scattered through both the lung. I would compare this with the previous. I would ask about the history of this patient, and I would go for CT for this patient. For sure, I would urgently refer this also for the chest tube referral to exclude them for the pneumothorax.
Okay. The CT scan.
Okay. In the CT, this is axial cut CT. Just 1 second.
Scroll slowly.
Okay. This is the axial cut CT for both the lung. I can appreciate the previous left pneumothorax, and in both the upper lung, I can appreciate that there is evidence of bilateral bronchiectatic changes noted with mucus plugging noted within it, and also there is evidence of fibrotic changes appear to be affecting morely the upper lung zone. However, it extending also down to the lower lung zone. I'm trying to exclude, yes, there is evidence also of some nodular opacity with branching, some nodular nodules, tiny nodules with branching opacity, giving a tree embodied appearance, suggesting endobronchial infection on top of cystic fibrosis. This confirming the finding. I just will refer this patient again for the chest MDT after putting chest tube and comparing with the previous, and also giving for starting for antibiotic for this endobronchial infection, and looking for any other association, especially in the upper abdomen. If it's available in the mediastinal window, I wanted to look for the pancreas. Okay. In the mediastinal window. Sorry, yes.
Hold.
Yeah. Okay, in the mediastinal window, I wanted to look for the pancreas and the upper abdomen also. Just for confirming and to look for the association. Okay, I can appreciate that the pancreas appear to be lipomatous hypertrophy. So this is confirming the diagnosis of cystic fibrosis because it would be
Okay.
associated with.
Okay. Any lab investigation for cystic fibrosis patient?
Yes, I really forget it now, but
Okay, sweet chloride test. Okay.
yes, with chloride test. Okay.
And this patient needs referral to lung MDT for empirical antibiotic and cultural sensitivity and further follow-up. Okay, well done. Thank you. Okay, your second case, you did it very well. Okay. Yes, ring-like cystic changes on both lung beats, predominant upper lung zones. Here, very important to mention pneumothorax, likely to be chronic because there are some situations like this, but it is very, very important to mention it. You can see here the visceral pleural line on the left side, relatively sparing the lower lung zone. There is some obliteration on the right side. Heart or bones or things appears normal, so it is predominant upper lung zones cystic lung disease. Cystic fibrosis is first differential. CT scan confirms the presence of cystic changes and tree but as you told everything very well, and most important, you asked for mediastinal window to see any associated lipomatous transformation of the pancreas. So it was a case of cystic fibrosis. Actually, this case, okay, you reaches the diagnosis at the end, but you will lose some marks of your observation. Okay, I feel that your first case, you are feeling some stress,
Yes.
but there is some bilateral subdural collection here. As you told, there is abnormal appearance of the sinuses here. Okay, it appears rounded and distended. Okay, you can also look at the foramen magnum, no any associated herniation or crowding. Okay, but bilateral subdural collection, both on your mind, may be hemorrhagic, may be sign of intracranial hypotension with associated rounded shaped of the venous sinuses and transverse sinus on the right side. You can go for the flare. You can see the back images is thickened, post contrast, diffuse meningeal, smooth meningeal enhancement is seen, and also the sinuses on the lateral or the sagittal view. The other signs, as you told, maybe some sagging of the midbrain, but here not so much. Also, the engorged pituitary will be a sign also of intracranial hypotension. This will differentiate it from hypertension, which will be a partial empty cella. Okay, and you can ask for the cause. You can do whole spine MRI or ask for any previous operation or lumbar puncture because the causes of intracranial hypotension may be idiopathic, may be secondary to any previous injury to the dura or CSF leak. And as you told, we will refer this patient to a neurosurgical team if there is any primary cause or a neurology team if it is an idiopathic. Okay. Well done. All the best, inshallah. But both of your cases you did very well. Just just need to, and this will happen in the exam. By the way, you may feel some stress in your first case. Try to be relaxed. Okay. Don't be worry about or stressed about the exam. Try to go systematic, and inshallah all the best. Thank you so much.
Thank you.
Candidate 2.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. Okay, doctor. You can ask for the remote control, please.
Okay.
75 years old patient with trauma.
I am presented with sorry, doctor.
Just scroll by your trackball or arrows up and down. Click once on the screen, doctor, and use your trackball. It's the easiest method to scroll.
Not scroll.
Click once. Click once. What are you using while you are scrolling?
Mouse.
You have trackball or not?
Yes.
Okay, use your trackball like this, okay? Just click left click once and use your trackball.
Okay.
This is the last cut, doctor. You can go in the reverse direction. Yes.
I am presented with the CT axial cut brain. I will scroll through the image till last cut. This CT without contrast.
Scroll slowly.
No, no crowding of the foramen magnum. No obvious abnormality can be identified, and only atrophic change of the brain.
Doctor, please.
Doctor.
You will not go up and down all during the exam. Just one scroll up, one scroll down. So scroll slowly, okay? One up, one down, and then start to talk. But not scrolling so much, not accepted in the exam, okay?
Okay.
You can start scroll and start talk. Slowly. Slowly, okay? One by one.
I will scroll through the image, CT brain without contrast. I see atrophic change of the brain age related. There is a high signal, a hyper intense signal, a hyper intense lesion seen in the left temporal loop. No other abnormality can be identified. No midline shift. No hydrocephalic changes. The only abnormality identified, this is abnormal high density signal seen in the left temporal loop. Maybe this one cavernoma. or malformation, arteriovenous malformation,
Do
paranasal
you remember
sinus
the
is
history of this patient?
unremarkable. Sorry,
Do you remember the history of this patient?
75 years old patient, but I not remember history.
It's very important in the exam to remember the history. Okay? Don't ignore this point. This patient presented with trauma.
Trauma. And no hyper dense signal in the subarachnoid space or
Please,
subdural
doctor, please. I will
spaces.
give you one advice. Okay? Don't
Okay,
give no, 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 no. All this no, except you are sure there is no abnormality. Okay?
okay,
Let this at the last of your list. I'm searching for, I'm looking at this, I'm looking at this. But don't tell, no, 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 no. This means that you didn't look well. Okay? There may be abnormality in the region that you told this is normal or no any abnormality. So keep no at the end. Okay? After you finish all the abnormality first, and then go for pertinent negative finding. Okay, what are the
you
check
can see
areas of?
hyper intense signal at the parietal left parietal region.
Okay,
This hyper
yes,
density signal in the left fronto-parietal region, and
okay.
also the hyper dense signal seen in the temporal left temporal.
Ignore this.
Maybe
This is the
this.
internal carotid artery. Okay,
Okay. In my daily practice, I want to check bone window to see if any related bone fracture.
okay. I want to tell you another thing. If you ask it for another sequence or another window and you lost the finding in the main window, you will lose so much marks from your observation. Okay.
Okay. Bone window for the same patient. I will scroll through the image to see the area of interest, the high density in the seen in the brain window.
Try to be more systematic, please.
Okay.
What are the check areas
No
of the
obvious,
bone window? Wait,
no
doctor. What are
obvious
the check areas of bone window? What you will check in bone window?
any bony fracture,
Okay, where?
the skull, then
Okay,
skull base, both
okay,
orbit.
okay. Both orbits and paranasal sinuses. Please
Yes.
look at this list you told me now. Scroll slowly, please, and go to these areas one by one.
Okay. No, there is
Look at the right orbit, please.
fracture here in the right frontal sinus with a
Where is the
subglial
fracture?
hematoma. This one is subglial hematoma here in
Okay,
the right frontal.
okay,
This one.
okay.
This is fracture in the lateral orbital wall, right
Very
side,
good, very good.
associated with
What?
the ear foci and also ossification in the right maxillary sinus.
Okay. What about the right orbit itself? Okay, I will give you the soft tissue window again, but this will not happen in the exam.
Okay. I will check the right orbit in the soft tissue window. There is a collection in the preceptal area of the right orbit. No dense dislocation. No rupture in the globe. Only the collection seen in the preceptal area. Preorbital collection associated with the lateral fracture in the lateral orbital wall. In my daily
Okay,
practice, I will urgently
I will
refer
give
patient
you
to
I will give you
pathology.
one thing. In the exam, no examiner will bring for you one case for to mention some fractures, some preorbital hematoma. There should be something bigger than this. Okay. Wait, doctor. Don't give up in the exam, by the way. Okay. What is this?
Superior ophthalmic vein.
Okay, what's happening?
Prominent superior ophthalmic vein with the
What
carotid
are you
sinus,
suspecting?
carotid cavernous fistula.
What will you do next?
MRI to see the carotid cavernous fistula and confirm
Is this patient
diagnosis.
on the table?
I will make contrast.
Okay. There is a code.
Yes, there is enhancement of the right cavernous with the same at the same time of the superior ophthalmic vein. This confirm diagnosis of carotid cavernous fistula.
How will you manage this case?
Urgent referral to ophthalmology and a neurological team.
Ask you yourself one question before refer the patient to one team. What will this team do for this patient? What will the ophthalmology do for this patient?
Um, I don't know.
Okay, so we will not refer this patient to ophthalmology. Carotid
Okay.
cavernous fistula. What we have to do for this patient?
Neurosurgical team to repair the fistula.
Interventional neuroradiology team to close fistula. Okay.
Okay.
And by the way, this patient did conventional angiography. Okay, for coiling. You did two cases or one case?
One.
One case. Yes. Okay. This patient, 40 years old female patient, came with abdominal pain.
I am presented with the coronal abdomen with the IV contrast. For patient 40-year complaining of abdominal pain, I will scroll through the image till last cut. I can see a large cystic lesion in the pelvis extend up to the abdomen, cause the lateral displacement of the uterus to the left side, and also compression of the urinary bladder down in the pelvis. The lesion show internal septal enhancement. This lesion not separable from the right ovary, but I want to check in other cuts. No ascites or pneumoperitoneum can be identified. Kidney, liver, and spleen unremarkable apart from hypo-intense lesion seen in the liver, right loop. In my daily practice, I want to check this in other cut. I will put differential for cystic lesion with enhancing septa inside and uh, nodular inside. First differential, I would put for this one serous cystadenoma. Other differential is mucinous cystadenoma. In my daily practice, I want to check other view
Okay,
and
read them
see
out.
if any. Okay. Axial cuts for the same patient. Confirm diagnosis of cystic lesions in the pelvis.
How will you differentiate between right and left neck subluxation?
According to position, I will see the position of the lesion. Uh, this lesion, this
Okay,
is this one
anything else on
arise.
this patient? Anything else on this patient?
I really want to see other ovary and exclude if this lesion may be metastasis from other organ such as stomach or colon to exclude Kirkenberg tumor.
Okay.
But I see colon unremarkable.
Where is the colon?
If this patient has ileostomy in the right side, if this patient has a history of removal of the colon before, I will put differential of familial adenomatous polyposis, and maybe this lesion is desmoid in the abdomen. I want to see previous history of the patient, if patient has familial adenomatous polyposis before, because maybe this desmoid in the abdomen, because the
No,
ileostomy surgery before.
no familial adenomatous polyposis. Anything else?
Patient has the colostomy before, and this lesion is desmoid in the pelvis, extend up to the lower abdomen.
Where is the
Also,
location of this desmoid always arising from? Will desmoid
sometimes,
arise from the ovaries?
لا, no, separable from the ovary.
This is separable from the ovary?
Maybe this patient has a previous colonic cancer, and this
Okay.
lesion is Kirkenberg tumor metastasis to the ovary from the previous colonic cancer.
Okay. How will you manage this case?
Urgent refer patient to oncology team. Request for CT chest, abdomen, pelvis to see if any other metastasis.
Okay. Thank you. This case, if you see, okay, this is the ovarian mass with some large cystic changes. So our differential may be primary or ovarian mass or metastases. Okay. So you have to search for any association. Always in any case, you have to search for the pathology first. then search for the cause, then for the complication, then for association. Okay. So always, if you found one pathology, okay, try to look for the cause, try to look for the complication, try to look for the association. Okay. Here, okay, maybe primary, but maybe secondary. So as you told, I need to exclude any associated colonic mass, gastric mass, or any previous or appendiceal mass or breast mass like this. Here, what is this?
Previous surgery. Site
There
of
is
previous
surgical,
surgery.
yes, there is surgical clips here. I think through the sigmoid, and also there is colostomy here on the right iliac fossa and large ovarian mass. To differentiate between right and left ovarian mass, you have to follow the ovarian vein. If it is going to the mass on the right, so it will be right ovarian. If it is on the left, it will be left ovarian. Unfortunately, this case this is not full study, so you can differentiate between right and left in this method, because sometimes the mass will be huge and will be in the mid line. Okay. So it was a case of Krockenberg tumors. There are bilateral mild hydronephrosis to be evaluated. Maybe the patient need some drainage, but not so much need urgent referral to urology. Okay, CT chest, abdomen, and pelvis. Check previous imaging and refer the patient to oncology MDT. This case, always try to, if you couldn't find the abnormality in your first look, first of all, you have to scroll like this, okay? Don't, in the exam, you can scroll like this, but don't do this, okay? Scroll slowly. Start from up, down, or down, up as you like, okay? But while they are scrolling, you should look well what's happening. This patient is presenting with trauma, okay? Trauma, I am searching for any hemorrhage, okay? So as you told, there is small left-sided subdural, hyperdense subdural collection, okay? And there is here subgaleal hematoma, foreign body likely here, okay? No intraventricular hemorrhage, and this I think is atherosclerosis of the internal carotid, left internal carotid artery, okay? And you have to go for any association with facial fracture. Here, hyperdense subgaleal collection, and you can see the right orbit, preorbital hematoma. There is hemosinus seen through the right sphenoid and the right maxillary. So something happening here. At this time, you have to concentrate on this area. I'm looking at the orbit well, okay, go up. Ophthalmic vein, very important because this patient is 75 years old, okay? He's not a young patient, he's a very old patient. So traumatic carotid cavernous fistula is a possibility. And you can see here there is the right cavernous sinus slightly bulky. So if you go through this and you will find the superior ophthalmic vein hyperdense, you have to suspect carotid cavernous fistula. At this time, you can ask for the bin window to ask for to see any associated fracture like this, and then urgent contrast study if the patient is on the table. If the patient not on the table, I will recommend MRI and further referral to a neurointerventional team for digital subtraction and geography for coiling and closure of the fist. Okay? Don't be stressed. Try to be logic. Okay, all the best, inshallah. Thank you. Okay, can 3?
Yes, sir.
Can you ask for the remote control?
Yes, sure.
Okay, approved. I'll give you the history form. Wait. 20 years old male patient with renal colic.
Okay. This is a frontal radiograph of the abdomen and pelvis of a 23-year-old male patient who presented with renal colic. And okay, I'm looking at the left renal shadow that appears enlarged, and a few calculi like hyperdensities are noted within this renal shadow. And the psoas muscle appears intact, the psoas shadow. Like, however, I cannot appreciate the psoas shadow due to projection of the overlying bowel. And apart from this, I'm trying to look for any other significant abnormality. And okay, I could appreciate that there is a right-sided sacroiliitis uh, and left sacroiliac joint appears unremarkable. No other significant abnormality is noted. I would proceed with CT KUB to further assess the patient
Okay.
condition.
What are the possibilities for this calcified renal shadows in the renal areas?
Most likely, it is presenting a small renal calculi or yeah, yes, small calculi or concretions.
Okay.
Yes. Okay, now I'm provided with CT KGB,
Okay.
and I'm scrolling from cranial to caudal, and I'm going to the point of interest. Sorry, it is,
Just scroll slowly
yeah,
to see the full stack of
yes.
images.
Yeah, I was scrolling slowly, but it jumped.
No,
Okay,
no, just one by one
okay, okay.
and wait. Inshallah, it
Yes,
will be good.
yeah, okay, okay, okay. Now I'm scrolling to the point of interest towards the kidney. Okay. In kidney, I can in bilateral kidneys, I can appreciate that there are multiple calculi noted, and these are in the area of renal medulla, and so I'm suspecting that this is likely representing a medullary nephrocalcinosis, and the differentials for it include medullary sponge kidney, renal tubular acidosis, and hyperparathyroidism. And as I was scrolling, I could appreciate that there was a lesion noted, yes, here in the tail of the pancreas. I would also like to look at its relation with the stomach. Yes, because here it is in close proximity to the stomach. So I would like to look at the coronal images for further assessment, as in my routine practice. Okay, now I'm provided with the coronal images. Okay, I'm trying to scroll for it. Okay, here I could appreciate that the same findings are redemonstrated. There is bilateral medullary nephrocalcinosis, and this lesion, which was seen earlier, is seen to be arising from the uh, stomach as an exophytic lesion, because I cannot appreciate the intact fat plane at this level between the stomach and the lesion. And or maybe it is from the tail of pancreas. I would still like to further delineate this area on any on the sagittal plane as well. And apart from this, I would like to look at the bone window to look for uh, whether hyperparathyroidism is the cause of this medullary renal nephrocalcinosis.
Is this it then?
Okay, I can appreciate that uh, this is
Okay.
not the soft
If you
tissue window,
found
though.
if you
This is,
found the pancreatic mass,
yes, yes.
what will you do next?
Next, I would correlate with the serum CA 19-9 levels, as it was a
Actually,
hypodense lesion.
should do
And
contrast study. Contrast.
okay, yeah, contrasted first. Okay. Okay. Sorry, it is jumping a lot. Okay, yes, here I
Wait,
can appreciate
scroll
that.
slowly and you
Yes,
can.
yes, yes. Okay, at this point, I can appreciate that the lesion appears cystic and with some solid component maybe, and it is well defined and rounded, and okay, there is no evidence of any pancreatic duct dilatation, and there is no evidence of any other intrahepatic biliary channel dilatation. So this looks more like a benign lesion, not adenocarcinoma. So I'm thinking on the lines of mucinous or serous cystadenoma. But as the patient is young, so I'm thinking more on the lines of mucinous cystadenoma and no, or it can be any residual pseudocyst of the pancreas from any previous episode of pancreatitis. However, at present, no evidence of any pancreatic fat, peripancreatic fat stranding is noted. And
Anything else?
okay, uh, for the pancreatic lesion.
Anything else?
Uh, mm, it could be, as it is not hypervascular on the arterial phase study, so it rules out any neuroendocrine tumor. And as it is not a very solid lesion, so adenocarcinoma of the pancreas is also being ruled out. And other differential could be have been very less likely that it is any side branch IPMN because it is just a focal, rounded, well-defined lesion. And so I'm thinking more on the lines of benign etiology like serous or mucinous cystadenoma, but as the patient is young, so likely mucinous. Or another possibility could be that if as sorry, I can know the age of the patient once again, please.
Young age,
Young age. Okay, then solid pseudopapillary tumor can
20s.
also be put in different. Okay, okay. So solid pseudopapillary tumor of the pancreas can also be one of the differential because it was solid and cystic in nature.
Okay, can you scroll again through the pancreas, please?
Yes. Okay. Yes. There is minimal prominence of the pancreatic duct, but not dilatation. And yes. Okay, I can see bilateral adrenal glands appear unremarkable. And
I'm asking about the pancreas.
yes, okay. The rest of the pancreas appear uh, showing normal parenchymal enhancement and uh, no evidence of any peripancreatic fat stranding, as I earlier mentioned. And I would also like to look at in the venous phase images for further characterization of this disease process. Okay, now I'm provided with the venous phase images. And I will go to the point of interest in the pancreas. Okay, here I could appreciate that the
Can you
lesion is
correlate
showing
with
solid
between,
component.
please, can you correlate between the pancreatic finding and renal finding?
Yes, I can correlate as there is a lesion in the pancreas and there is also bilateral medullary nephrocalcinosis. So I'm thinking of MEN syndrome. That
Which
is the
type?
pancreatic MEN 1 because I'm
Okay.
thinking that
What will you do next?
next I would look for the parathyroid adenoma, ultrasound of the thyroid. And also, I would look at the pituitary gland with the pituitary protocol MRI. Yes, now I'm provided with the nuclear study at the level of the thyroid gland, in which I can appreciate that there is an increased uptake within the
What
left
is this?
parathyroid
What is this
adenoma.
study?
Most likely, it is a system EB scan in which
Okay.
it is a delayed phase, and I can appreciate that
This
on
is
the
delayed.
2 hour studied. Yes,
This is
on the
delayed.
2 hours. Yes, because there is more contrast in the, sorry, there is more uptake within the parathyroid adenoma rather than in the thyroid gland. So
How will you
maybe it
differentiate
is
in maybe scan between thyroid and parathyroid lesion?
on the MIPI scan in the earlier phase, it shows uptake within the both and
Okay.
at 5 minutes. And on the delayed 2 hours study, there is a retained uptake within the parathyroid adenoma only. So on the basis
Okay.
of
Here
that,
is
we
uptake only in parathyroid or thyroid and parathyroid.
both, both,
Okay.
but
So this
more in
is
the
early.
parathyroid.
Okay.
Yeah,
Well,
yeah,
this early study. Okay.
yes. Okay, now I'm provided with the delayed. Yes. Here I can
Okay. Give me your
appreciate
final
that
diagnosis management, please. No time.
this is a Men-1 syndrome, and next I would send the patient to the multi-system MDT, in which multiple specialists from head and neck and
Okay. What
endocrinology
could
would
be
be
the
involved.
management of this patient?
In this patient particularly. Okay.
Yes, of course.
mm, Next, I guess parathyroid adenoma would be removed,
Okay.
and
Thank you.
for this, yeah.
Thank you. Okay. This patient is a 35 years old female patient with infertility and history of ectopic pregnancy. You can scroll
Okay,
through the
history of it.
images.
Okay.
Infertility
I provide.
and ectopic pregnancy.
Okay. Okay, these are hysterosalpingogram images of a female patient who presented with history of infertility and ectopic pregnancy previously. In this study, I can appreciate that there are two cornua of the uterus, which are far apart from each other, which is in favor of bicornuate uterus. And
Wait. Don't go for the diagnosis from your first talk. Try to
okay,
describe more, scroll through the image, give a differential.
yes.
Okay, this is not
Okay,
a
okay,
spotter exam. Okay.
okay. Okay, in these images, I can appreciate that the contrast is outlining the both cornua of the uterine cavities, and
Okay,
contrast
you
is
can
also seen
describe
out.
it. You can describe it two uterine cavities. Don't tell this
Yeah,
both
two
cornea
two
or two
uterine
cornea.
cavities. Okay.
Yes. Okay,
Two
because we have a
uterine
differential here.
cavities. Okay,
Okay.
okay. Yes, two uterine cavities are being outlined with contrast, and I can also appreciate that the contrast is outlining bilateral fallopian tubes. And now I'm trying to look for the spillage of contrast into the peritoneal cavity. Okay, I'm scrolling through the images to look for it. Okay, okay. These are okay. Here I could appreciate that there is the contrast is not freely noted within the peritoneal cavity, and there is contained leakage on both sides, especially on the. Yes, here I can appreciate that there is contrast within the peritoneal cavity, but no contrast. Free spillage is noted on the left Left side. This looks more like
Okay, there are bilateral spillage of the contrast. Ignore about the tubes. What's your differential of the uterine appearance?
yes, I'm suspecting that the contrast leakage is contained leakage and not free spillage
Ignore
within
about
the
that.
peritoneal.
Ignore
Okay.
about that.
Mm, okay, there is some intravasation also noted on the left side. But no, I think that this is the
Doctor,
tube.
can you hear me well?
Yes, yes,
Ignore
yes,
about that.
yes.
We asking about the uterus itself. What's your differential?
Okay, uterus. Okay, okay. I thought you are okay. Yes, the uterine. There are two uterine cavities which are widely apart from each other, and there is a dip within both the uterine cavities that is deeper than 1.5 centimeter. And so I'm suspecting that this is more likely uh, septate or biconvate uterus. And on the basis of the angles between these two cavities, if this is more than 105 degrees, then it will be biconvate uterus. If it is less than 105 degrees or less than 75 degrees, in fact, then it is more in the favor of septate uterus. But as you have told the history of infertility in the past, so I'm thinking that it is likely representing a septate uterus.
What will you do next for this patient?
Next, I would proceed with the MRI to look for the myometrium of the uterus, myometrial contour.
Okay.
Okay,
Here is the coronal
yes.
images.
Okay, these are the coronal images, T2 weighted, of the female pelvis, in which I have seen two uterine cavities earlier on the HSG. I'm trying to scroll. Sorry, it is not scrolling. Okay, now it is. It is not scrolling. I'm trying.
Scroll slowly. Okay. What is the
Okay.
line of the cut? You will ask the MRI technician to differentiate between both intensities of bicornate or septate.
Biconvate or septate. Uh, sorry, I don't understand your question. What I have to tell the radiographer or technician?
Yes. Any specific protocol for the MRI?
Uh, okay. That would be, I guess, taking the images in exact
Okay.
uh,
I'll give you the sagittal.
perpendicular to the yes,
Yes.
perpendicular
This
to
is
the uterine cavities to
okay.
take the
Can you
two
show me
images.
how he will take the axial and the coronal?
Okay, that would be perpendicular to the long axis of the uterine cavity. So that is
Which
how he would take.
which which plane?
This is the long axis in this case.
Okay. Okay.
Yes. And for the other cavity, he would, yeah, I guess, yes, to the perpendicular to the long axis of uh, one of the cavities, and I'm not sure about it. Sorry.
Okay, no problem. Here is the
Mhm.
axial or axial as regarding the planes they
Yes,
talk in
yes,
MRI. Okay.
yes.
But
Okay,
actually this coronal.
okay, okay.
This coronal
In
on
this,
the uterine axis itself. Okay.
okay, okay,
The technician will take the axial on the pelvis. Okay.
okay,
But
okay.
according to the axis of the uterus, okay, he should
Yes,
make the planes perpendicular on the axis of the uterus, not the axis of the pelvis. Okay?
Yes, yes, yes. That's what I
Because
meant.
here,
Yeah.
here is the coronal, is very important. What is the value of the
Yes.
coronal here?
We have to see the exact fundal contour. If there is a
Okay.
dip within this, then it is more in the favor of septate uterus. And if it is a smooth contour or bulging contour, then it is more in the favor of a bicornuate uterus. As I can see, there is
I
a
think
small dip here.
the reverse.
Okay, maybe.
Not
Yeah.
maybe.
Okay.
There
Okay.
is
Yes.
fundal cleft more than 1.5 centimeter.
Yes.
Okay.
Yes. Yes.
It favors
Yes.
bicornuate uterus.
Yes.
If the
Yes.
fundus
Yes.
is preserved and there is a septum, so it will be
Yeah.
more
Septate
to
uterus. Yes.
septate uterus. What's
Yes.
your final
Yes.
diagnosis and management?
This is uh less than 1.5 depth. So I'm suspecting that so I'm thinking on the lines of a septate uterus. And next I would convey the findings to the gynecology team for the removal of the septum, and this will improve the fertility outcome.
Okay. Do you know the name of the
Yeah.
operation?
No, I don't know the name
It's
of
called
operation.
metroplasty. Okay. Metroplasty.
Okay, metroplastic. Okay, okay. Thank you.
Okay.
Thank you.
You did well, but you are struggling. I don't know why. Okay. You are thinking well, but you may feel some loss of confidence. I don't know. Okay. This
Okay,
case,
thank you.
okay, hysterosalpingiography. Okay. We have to comment on the uterine cavities. We have here, don't told the uterine cornea or horse like this. We can make a broad term, two uterine cavities separated from each other, widely separated. I can see the contrast through the both fallopian tubes. Okay. Uh, I will scroll through the image. There is some spillage here and some spillage here. Okay. And here also. No so much dilatation of the distal fimbrial end of the both fallopian tubes. And here there is a spillage. Okay. This about the tubes. About the uterine cavities, I can see one cervix. This is not two cervices. So we excluded here what? Candidate 3?
Sir, didelphys or
Didelphys.
bicornuate
No.
bicollis. Yeah.
Yes. So one uterine, one cervix. So we excluded didelphys or bicornuate bicollis. Okay. Then we will go for the uterine cavities. There are two uterine cavities separated from each other. But here in hysterosalpingiography, we couldn't see the myometrium. So we have two differential here. Maybe septate uterus, maybe bicornuate uterus. To take this patient further, we can do 3D ultrasound or correlate with the ultrasound finding and then go for MRI. Okay. MRI, the most important one will be the coronal. Okay. Here, as this is the axis of the uterus itself. So if we talk like this, it will be axial. Okay.
Yes, yes.
Okay. So
Yes, sir.
we have to take coronal on the axis of the this no. This is the usual axis on the pelvis, axial on the pelvis. Okay. So if we talk like this, okay, this will be the axial on the uterine uterus axis. Okay. So we have to take the coronal like this. Okay.
Yes.
Coronal will be like this. So here in the images, actually they put this image as axial image, but actually it is a coronal image on the uterus. Okay. And they put this a coronal, but actually it is the axial image of the uterus itself. Okay. This is the difference. We
Yes.
are making the planes along the uterus axis, not the pelvic axis. Okay. So the most
Yes.
important one is the coronal. Why? Because the coronal will give us the fundal contour. Here is the fundus.
Yes.
Okay. no more cleft. If it is bicornuate uterus, it should go down like this,
Yeah.
more than 1.5 centimeter. Okay,
Okay,
but
yes.
no more cleft. Cleft just slightly down, less than 1.5 centimeter. So it will be
Yes.
septate uterus, not bicornuate uterus. And by the way, the most common type cause infertility is
You septate.
septate. Yeah.
Yeah.
Bicornuate uterus, the patient may get pregnant easily in one cornu. Okay,
Of the, yes,
but
yes.
the implantation on the septum will make failure of the pregnancy. So the operation will be removal of this septum, and it is called metroplasty. Okay, and we should
Thank you, sir.
also welcome this patient. The story fell can see multiple
Yes.
calcified shadows here.
Yeah.
Okay, and on the right side here, and on the pelvis here. I can mention it here. One. Okay, and multiple here on the left side,
Yes,
multiple.
yes.
Okay, so the differential here will include multiple renal calculi and also multiple medullary nephrocalcinomas. Okay, so we can go for ultrasound first, or we can do the CT scan. Okay, CT scan. Okay, we confirm the presence of renal hyperdense shadow, but it is not likely to be renal calculi, as you told it, more to be calcified
Medullary nephrocalcinosis.
medullary nephrocalcinosis. Okay, but while we are scrolling, if I asked you for the differential for medullary nephrocalcinosis, what will you give me the differential?
I told earlier, sir, that it would be renal tubular acidosis,
Okay,
hyperparathyroidism, and medullary sponge kidney.
very
Three
good.
differentials.
Okay, okay, very
Yes.
good. While we are scrolling, we found pancreatic mass.
Yes.
Okay, so we have to think rapidly in any association. Okay, I have
Yes.
pancreatic mass and I have renal medullary nephrocalcinosis, so I should put in my mind any parathyroid abnormality, and then it will be men type 1. So
Yes.
rapidly, I need to first to ask for the contrast study. Okay, to
Yes.
delineate well this pancreatic lesion and search for another pancreatic lesion.
Oh,
Most
yes,
common
yes.
pancreatic lesion in men type 1 is
PNET. Yeah, pancreatic neuroendocrine tumor.
neuroendocrine
Yes, here
tumor.
I,
Okay,
yes, this is
so you can,
hypervascular.
yes, I asked you to go through the pancreas, but unfortunately you are concentrate on the same region. Go to the
Yeah.
whole pancreas, head, body, and tail, and the unsned process also. And we should
Yes.
also here look at the liver for any associated metastases. Okay, hypervascular
Okay.
metastasis. Okay,
Mm.
so here
Yes.
the case appears to be syndromatic. So then you have to
Okay.
assess the parathyroid. Most important
Okay.
thing to assess the parathyroid is systemic scan. Okay, here
Yes.
systemic early. We can see both thyroid and
Yes.
parathyroid, but slightly more
Yes.
parathyroid. We need the delay to the thyroid to be washed out and let the parathyroid adenoma. Okay. For the pancreatic
Yes.
tumor, we can do gallium dotatate scan or octreotide scan. Okay, so it is case of men type 1 and maybe associated with pituitary lesion. We have to refer the patient to MDT and also removal for parathyroid adenoma and check serum calcium level and like this. Okay. So it was a case
Okay.
of
Thank you.
mental. Thank you so much.
Thank you, sir.
All the best, inshallah. Thank you. Okay, candidate 4.
Yes, doctor, I'm here. Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh. Okay, doctor. One day, patient with no available history.
Okay, so this I'm presented with frontal radiograph of the chest and the upper abdomen for neonate, which I would like to check first. There is no available history, and I can appreciate that there is a ill-defined area of. Sorry, I will request thermal control. Yeah.
Okay, in plain radiograph, no need to mention. Okay, you just describe anatomical wise. Okay.
Okay, I can see that there is an opacity noted in the left lower zone, retrocardiac. It has incomplete border, and I can see the superior border. The inferior border is not clearly seen. It's seen like under the diaphragm. The rest of the study, I will go through. Both lungs appear normal. The heart also. The heart is slightly. No, it's accepted. So the heart looks fine, and the visualized bones appear normal. So for this lesion, this may be an area of sequestrated lung, or maybe other differential, maybe small part of diaphragmatic hernia, but this is less likely because I can see the stomach and the bowel loops. The upper abdominal cuts appear normal. I can't see any branching airs or branching lucency over the liver shadow or any yes, and no intramural
Okay.
ear scenes in the bowel.
Okay. About
So
the lung lesion, what's your
yeah,
differential?
so
You
my
told me
differential is
sequestration.
pulmonary sequestration or small diaphragmatic hernia,
Okay.
or other pathology. So for this patient,
Like
um, maybe a small cyst, pericardial cyst or congenital cyst.
is it the typical location of precardial cyst?
No, this is not the typical location, but yeah.
Okay. What will you do next for this patient?
So for this patient, I would like to check for if there's any available CT, CT for chest, or MRI.
I can give you MRI. There is MRI. It's prenatal MRI.
Okay, so this is a perinatal MRI. I would like to check the images for this patient. I will go directly to the lung. Okay. Sorry, doctor, I'm trying to scroll. I'm using the trackball, but I don't know why it doesn't scroll.
It's the last cut.
Okay, this is the last cut. Okay. This is the liver scene, and this is the heart, and this is the. I'm trying to see the lung, and I'm assuming that this is a lesion that I can't see in the X-ray. I will try to see this.
Okay, I will give you the sagittal one.
Yes, please. Yeah, the lesion appear high signal in it's seen in the left lung lower lobe, and at appear high signal, well defined. So it's not purely cystic. So I will remove cystic from my presence of cyst from my differential, and I think this is
Anything else here? I will make zooming for you, please. Okay. You can scroll again. Anything inside this lesion will differentiate the
I can see that
different pathologies.
I think there is also hypointensity seen. Sorry, doctor, I'm trying to see, but the image is so blurry from my side. I think there is a hypointense area seen also inside the lesion. Oh, sorry,
Okay.
this was not the lesion.
Okay. Here's the CT scan.
Okay.
You can scroll.
Okay, I'm scrolling. This is an axial CT long window, and I can appreciate that the abnormality appear hyperdense seen within the lung, and it goes down to the pancreas. Doctor, can I check it in the soft tissue window, please? Yeah, I can appreciate that there is a vascular tertiary vascularity seen in this area. It appears to be arising from systemic vascularity from the aorta. So yeah, so I will keep sequestration as my main diagnosis.
Which type of sequestration?
This is intraluper sequestration.
How will you differentiate between intralubar and extralubar?
Intralubar sequestration will take arterial uptake from the aorta, and the venous will take from pulmonary vessels, the venous drainage.
Okay.
And here I think I think it's pulmonary vessels. The pulmonary veins is a venous drainage for this area. And I have checked the lungs. There is no other associated anomalies like
Doctor, I asked you one question.
Yes, sir.
If the examiner asked you a question, you should answer the question, okay? Don't go again for the case. He may finish the case with the questions, okay? How will you differentiate between intra and extralubar?
Yeah, sorry, I have answered it. I said for the intralubar, the arterial.
Okay, but you didn't tell the extralubar.
Yeah, the extralubar, the venous drainage will be systemic as well from the IVC.
Okay, about our lesion, can you show me the venous drainage? The differentiation will be in the venous drainage, okay?
Yes.
Both of them will take systemic arterial supply from the aorta, but the differentiation will be through the venous drainage of both.
Yeah.
And also the pleural covering and all those things, but we will not detect the pleural covering in the imaging. Okay, where is the arterial supply of this lesion?
This vessel are this tiny vessel.
Okay. Where is the venous drainage?
And the venous drainage, I'm trying to see. This is the venous drainage.
Okay.
So it's extralubar. I see this vessel.
Okay. Can you trace it?
I keep going. Yeah, this one.
Okay. Okay. So, what's your final diagnosis?
So it's extralubar pulmonary sequestration. It's not associated with any other anomaly in the lung. However,
what are the common association with extralubar sequestration?
CPAM, congenital pulmonary airway malformation,
Okay.
hybrid lesion. Also patient this would patient need to be referred to the pediatric specialist team to check the previous imaging, antenatal imaging, check for any other associated anomalies like cardiac anomalies or thank you. Okay, so I'm presented with
this patient. I will give you the history. In the exam, wait for the examiner to give you the history. Okay, 40 years old male patient with hip pain, No trauma.
48?
40.
40, okay, 40 with hip pain with no trauma.
Yes.
Okay, so I'm presented with a frontal radiograph of the pelvis for a patient with hip pain with no trauma, which I can appreciate that there is multiple lucent areas noted within the proximal femur and also the iliac bone and the acetabulum, with abnormal contour of the femur, and in areas of sclerotic septations inside. It's appear multi-septated lesion, and I would like to check the other bones. There is no abnormality noted within the upper bone. I will go back for this lesion. It's mainly in the right side. There is no. I'm checking now to see if there is any pathological fracture. I can't see any pathological fracture there, and no periosteal reaction. There's mild joint effusion noted within the hip joint, within the right hip joint. And I can't appreciate cortical breach or cortical destruction.
Okay, what's
So
your
this is
differential?
likely to be non-aggressive bone lesion. My differential may be fibrous dysplasia, or aneurysmal bone cyst. So for this patient, I would like to do a further assessment by MRI.
Can you see the extension of the lesion? Full extension of the lesion?
No, so I would like to have MRI for the whole limb. Bone scan also need to be done for this patient to check the whole extent and rule out if there is any.
In usual practice, we can
orthotic.
do bone scan for
Bone scan will be done for
malign
this.
lesion.
No, it might be done after MDT discussion, but here I would like to do MRI for the whole limb.
Okay.
Okay.
We can ask for, because here we couldn't
Other
see the full
orthogonal.
extension of the lesion.
Okay.
You can assess the whole radiograph to see the extension of the lesion.
Okay. So yeah, I can see that the lesion has a wide zone of transition. It is seen involving the whole femur, the whole visualized part of the femur, with mild endosteal scalloping of the cortex, with no break in the cortex. And some
Okay, what is the value of MRI here?
Sorry.
What is the value of MRI?
The value of MRI to assess the whole limb, to check for any scalp lesions.
Is it malignant or benign lesion?
It's benign.
Okay, then
MRI maybe also rule out any non-visualized. I can't see fracture, but we can assess if there is any pathological fracture as well.
okay. Here is MRI.
Okay, so for the MRI, I can appreciate that this is MRI for both femurs. The abnormality is seen. The abnormality is seen in the only in the right femur. It shows this is an coronal T2.
Is this T2?
Sorry, doctor, I thought the bladder is high. No, this is T1.
Okay.
And I can appreciate that there is abnormal high signal lesion seen within the femur. It extends to the distal metaphysis. Sorry, I'm trying to scroll. It's like with no abnormal cortical breach, no abnormal. I would like to check also the stare to see if there is any edema in the surrounding soft tissue. Yeah, there is no edema noted within the surrounding soft tissue. Sorry, doctor, there is a
Slowly, slowly to see the full stack of image.
I'm trying to use the arrows now.
Okay, give me your final diagnosis, please, and management.
Yeah, but my final diagnosis, this is a case of fibrous dysplasia. Patient need to be seen. Patient need to be sent to the orthopedic team, and also discussed in the orthopedic MDT. Also, patient need we need. Sorry, now I can appreciate that there is a high signal seen within the surrounding soft tissue. This may be myxoma. So this may be a syndrome like Mother-Pratt syndrome for
What
multiple
are the syndromes associated with fibrous dysplasia?
fibrous dysplasia, Mother-Pratt syndrome, and the Macon-Albright syndrome. But this
Okay.
will be in young patient with precocious puberty and fibrous dysplasia. And
Mother-Brown, what is the component of Mother-Brown?
fibrous dysplasia with a muscle myxoma, soft tissue myxoma.
Okay, thank you.
Thank you, doctor.
Okay, doctor. Why I'm feeling that you are under stress?
Because I can't do the scroll. I'm trying to do by the mouse and by the
Even in the radiograph.
arrows. I can't do that.
Okay, don't feel stressed. We are just practicing and learning, okay? You
Okay.
should be confident. Okay, this case, okay, you describe this lesion, yes? This in the iliac bone.
And I can't see it in the in the MRI. No, I
see.
should see it.
Okay, I think this you couldn't see in plain radiograph. So you can multiple lytic lesion, expansile lytic lesion, so the right iliac bone and the right acetabulum and the right femur. But here there is expansile lesion with thinning cortex here. It is different from this pathology. Yes or no?
Yes, this may be secondary aneurysmal bone cyst.
Exactly. Okay. And this is the rule of MRI. Okay. Fibrous dysplasia, we don't need to do MRI in all patients. We can just do a skeletal survey to see other sites of fibrous dysplasia and then associated pathological fracture like this. Okay, but here the indication for MRI is this expansile lesion. Okay, here also another important point: we couldn't see the full extension of the lesion. Any lesion, we couldn't see the full extension. You have to make full radiograph of the limb, and also you should always ask for the other orthogonal view. Okay, because always in plain radiograph we do two views in all thing, one AP and one lateral or oblique or forward position like this. Okay, so there is expansile lesion and bone lesion in long bones and iliac bones likely to be polystatic fibrous dysplasia with another lesion, secondary lesion, likely to be aneurysmal bone cyst. Okay, so as we told, any pathology, you have to search for the cause, for the complication, pathological fracture or malignant transformation or something like this, and for any association like syndromatic lesions. So here they did for the whole limb, it involve also the tibia and this ground glass appearance, and here also long pathology in long bones. It was likely to be fibrous dysplasia. Okay, we went for MRI. This is a T1 MRI. Okay, there is infiltration of the bone marrow, but here the lesion. Can you see this lesion? It's showing fluid level, and also here. Okay, you should think what will be the association of the lesion. Okay, so it is very important. If you think like this, you will get the abnormality from any segment. And you have to ask for the axial also to see the fluid level here in the axial cuts, and also it confirms the presence of intramuscular hyperintense signal lesion, intramuscular myxoma. So it was a case of Mazabraud syndrome with secondary aneurysmal bone cyst. This patient should be discussed in orthopedic MDT for possibility of excision of aneurysmal bone cyst and bone grafting, and further follow-up on the sites of fibrous dysplasia. Fibrous dysplasia may turn malignant, but very rare, maybe osteosarcoma or fibrosarcoma like this. But I think it is less than 1 to 3% of cases. Okay, this case, I give you directly the X-ray, but actually it was ultrasound, prenatal ultrasound. Okay, here you can see the liver, and here's the stomach, and you can see here the lung abnormality, and there is systemic supply here through the ultrasound, and then they did MRI through prenatal area, prenatal period, and then you can find here the abnormality, and there is signal void through it.
Yeah, sorry,
Okay.
doctor, I lost the connection and I come back. Sorry.
Okay. So in you see the neonatal ultrasound, prenatal ultrasound.
No, I have.
Okay, we did first prenatal ultrasound. You can see this is aorta. Okay. And this is the liver on the right side, and this is the stomach, and this is the left lung, and there is systemic supply here. So it is likely to be pulmonary sequestration. They followed by MRI prenatal. Okay, as you described, there is slightly hyperintense area seen in the left lung. You have to look for the supply, which will appear as a signal void here in the sagittal through the colon here, the lesion, and here is the signal void here. Then we have to go for the CT with contrast to see the arterial supply and the venous drainage. If the supply is systematic, arterial and venous, so it is extra loopar. If the venous drainage through the pulmonary vessels, so it is intra loopar. Extra loopar associated with multiple anomalies, as you called CPAM, congenital heart disease, diaphragmatic hernia may be also associated with scimitar syndrome. Okay,
Yeah.
all the best, inshallah. Trust yourself.
Thank
All
you,
the
doctor.
best.
Thank you so much.
Thank you. Welcome. Okay, next one, candidate 5.
Yes, sir. Assalamu alaikum.
Alaikum assalam. Okay, 60 years old female patient with chest pain.
Okay, I'm presented with chest X-ray frontal projection of a skeletally mature 60 years age patient. The abnormality I can see is that there are multiple reticular opacities seen in the bilateral lung fields, more marked in the bilateral perihilar regions, with some areas of ground glass changes and opacifications. There is also upward diversion of hilar vessels is noted. However, the bilateral costophrenic angles do not show any pleural effusions. Bilateral hila appears bulky. There is also widening of the uh, right paratracheal. There is some whitening of the right at the right hilar shadow. There is some convexity noted, and however, no pleural effusion is seen, and the cardiac size is mildly enlarged. Now I'm looking at the bones. The left shoulder appears to be elevated as compared to the right shoulder. Could be due to any underlying abnormality such as Sprengel's shoulder. Now coming back to the lung abnormalities, I will like to zoom to look for any curly B lines. However, with the enlarged hilar and prominent
Okay,
pulmonary
what are the check areas of plain chest radiograph?
Okay, there are apices. I'm looking
Okay,
at bilateral apices. Um, the There is mild opacity on the left as compared to right, but no obvious mass lesion is noted. It could be due to the scapular shadow. Now, the other check areas are costophrenic angles and diaphragmatic contours. There is consolidation seen in the right paracardiac region, and there is setting of the right heart shadow as well. There is also some opacity noted behind the medial end of the right clavicle in the right lung. In a patient who
anything else?
presented with shortness of breath,
No shortness
sorry,
of breath, just chest pain.
okay, just chest pain. Okay, there is some nodular opacity noted in the
Anything
right.
else?
Anything else? Okay. Now I'm also looking at the bilateral breast shadows. I'm unable to appreciate any asymmetry. I'm looking at any evidence of surgical clips. Uh, so uh, uh, there are right middle lobe consolidations or air.
Ignore
There's
about the lungs. Ignore about the lungs, please.
okay,
Anything else?
okay, okay. So I'm now looking at the bones. I can see some, I think, paraspinal opacities in the
Bones
left
are okay.
retrocardiac. Okay,
Retrocardiac region is okay. Anything else?
okay. Now I'm looking at the diaphragms. The diaphragms appears to be raised. Right hemidiaphragm appears to be raised. Now I'm looking in the abdomen to look for any abnormal shadows. For any, I cannot see the gastric bubble on the left side. So, other possibility.
Okay,
Okay,
this patient presented with right hypochondrial pain and fever.
okay. I can see that there is some opacity calcifications and opacity in the right hypochondrial region, with some hyperdensity within it, and some lucencies are also noted. If I can take remote control, and
You can ask for the remote control.
okay.
Okay, approved. Can you show me the mentioned area?
Yeah,
Okay,
this one.
okay, okay, okay. What are you suspecting?
I'm suspecting any liver abscess. If the patient has right hypochondrial pain, I will like to take the history of any fever. There is also some hyperdensity within it.
Okay, what will you do next for
So I
this
would like to
patient?
further proceed with a contrast enhanced CT scan of the chest, abdomen, and pelvis.
Okay, we did ultrasound. You can scroll through the ultrasound first.
Okay. So these are the grayscale ultrasound images taken from the abdominal probe. First, I would like to have look on the ultrasound images. I can see portal range appears normal. Okay, I can see that there is a large mass, there is a large lesion seen in the right lobe of the limb 6. It is giving posterior accosting dirty shadowing suggestive of air foci within it. The structures posterior to it are not visible. So it is suggestive of air locules within these lesions. So I will urgently arrange a CT scan for further confirmation.
Okay, here's the CT scan. I just want to make some zooming for you. Okay, you can scroll.
Okay, thank you. All right. Here I can see that there are, I think I am, yeah, I am
You
on
are
the screen.
scrolling.
There is minimal right atelectasis, minimal pleural effusion. As I'm going down, I can see that there is mild ascites. Free air is also noted in front of the liver, anterior border of the liver. Now I'm going down. I can see that there is an area of mortal lucency seen involving the segment 6 of the liver. There is also fat stranding noted in along the bilateral kidneys. These mortal lucencies could represent any liver abscess which has ruptured and caused the free air anterior to the liver as well. I will like to see the contrast enhanced images if available. Otherwise, I will urgently pick up the phone and inform the findings to the referring team, and urgent GI referral would be advised. Okay,
Okay, here
so
is
on
the
the
post
post
contrast.
contrast, yeah, so on the post contrast images, so first I will like to have a look. There's redemonstration of right basal atelectasis. There is free air is again noted. There is also thickening of the peritoneal lining, suggestive of some element of peritonitis. There is there is discontinuity of the liver margins at these mortal lucencies in the inferior to this at the segment 6, which is suggestive of the ruptured liver abscess.
Okay, how will you manage this case?
I will urgently phone call and inform the findings to referring team, and urgent GI consultation and IR consultation would be advised.
Okay, what is the rule of GI consultation?
GI consultation would, after draining culture and sensitivity, GI team can like correlate with the LFTs and markers, and if needed, any.
What could
Uh,
be the possible causes for this case?
this could be due to pyogenic, or it could be due to amoebic. Inflammatory markers and any history of travel would be able to help in that case. And also, I would like
What
to see the bowel to look for any element of intritus as well, which I
what could be
think
the
it
causative organism for this abscess?
oh, it appears to be more. I think it appears to be more in amoebic type of abscess, as it has mortal lucencies, and I can also see some
Will
element
amoebic
of
abscess will cause gas inside the abscess? The amoeba
not
is a gas
simple.
forming organism.
Yeah, no, no, not simple amoebic abscess. It would be like superadded infection due to anaerobes.
Like, do you know or
Like
not?
it could be due to E. coli infection, or maybe due to Proteus mirabilis.
Okay, what are the complications?
Complications can include any rupture, any thrombophlebitis of the adjacent veins, and peritonitis, and also any sepsis, and any pulmonary artery thrombosis, or any venous thrombosis.
Okay, this patient, 35 years old female patient with persistent back pain.
Okay. I'm presented with MRI sagittal section of cervical spine, T1 weighted images of a middle-aged patient, 35 years old patient who presented with pain. As I'm scrolling through the images, I can see that there is no tonsillar herniation noted. Uh, Atlantoaxial distance appears unremarkable. I'm looking at the vertebral bodies now. The vertebral bodies show some marrow signal abnormality. They are diffusely T1 hypointense marrow. On the T1 it should be hyperintense. I want to see the T2 weighted images if available to look at the marrow.
What are you suspecting?
If I see T2 and stir and confirms the marrow abnormality, then this is diffuse marrow infiltration. So it could be due to any hemoglobinopathy such as thalassemia. It could be due to myelofibrosis or mastocytosis or leukemia, lymphoma.
Okay, ignore about the marrow, just degenerative changes. Anything else?
Oh, okay. Okay,
The last
now
cut.
I'm looking at the vertebral heights also. Sorry.
Okay, in the cervical spine MRI, what are you checking?
I'm checking for the orientations, for the disc spaces, are they normal or not? I'm checking for any prevertebral space lesions. Um, Prevertebral space appears to be unremarkable. I will also see adjacent organs, the lungs, the aorta.
Do you remember the history?
Yeah, neck pain, middle age,
Back pain. Okay.
back pain. Okay. There is subtle anterolisthesis, I think, of the one of the vertebra in the lower thoracic spine. Sorry, in the upper thoracic and lower cervical spine over here.
Okay, I'll give
They
you the
are,
T2.
I think, can you scroll
Wait.
for me? Yeah, because I think the scrolling is not smooth. All right, on the T2 weighted images, I can see that there are area of hyperintense signal intensity noted in the visualized mid-thoracic cord. I can see its proximal extent, its distal extent is not shown
Is
here.
it
So I will like
mid-thoracic?
to see the lumbosacral spine. Sorry,
Is it
intramedullary.
is, is it mid-thoracic area?
Yeah, this is mid-thoracic area. It is seen starting from this mid-thoracic region. And I want to see its distal aspect of the lesion, if there are any available cuts in the lower thoracolumbar spine.
Okay, you can scroll.
Yeah. Can you scroll for me?
No. In the exam, you'll scroll by yourself.
Okay.
Just my advice, scroll slowly. All of you take the whole stack one time. It will not go with you smoothly. Just click one, and follow the image by your eyes.
Okay. I think it's not scrolling.
You're scrolling well, doctor. Just scroll one by one. Okay.
Mm-hmm. I think I'm
Why you
unable.
are? I
Yeah,
will
it's
show.
not
I will.
scrolling. I'm not
Wait,
able.
wait, doctor. I will show just the scroll bar. Okay. Look at yourself while you are scrolling. Okay.
Okay.
Can you see the scroll bar? How are you scrolling? Wait, doctor. Wait. Look at the scroll
Yeah,
bar,
I'm not
please.
doing.
Yes, you can scroll like this. 1, 2, 3,
Okay.
4, like this. Not like this. not like this. It will not respond to you, okay? Just click once and go one by one.
Okay. All right, so I can see that there is a focal area of T2 hyperintensity in the visualized cord, which is causing mild expansion, and it is involving the short segment.
Anything else?
I want to see the axial images, axial T2.
Okay, okay, use those. Leave the mouse.
Yeah, I've left.
Okay, you can scroll, but scroll slowly. Click once,
Okay.
one by one.
All right. As I'm scrolling, I'm going down to the area of interest. I can see that there's area of hyperintensity seen involving the spinal cord in the center. I can see that there are also some T2 hyperintense nodules seen in the skin, which could be suggestive of any cutaneous nodules. There are
Okay,
hyperintense signals seen in the
what's your
left
final
posterior
diagnosis?
So these nodules could represent any neurofibromas, and this is one of the lesion which is going outside the neural foramina on the left side. This could represent
Okay,
any lateral meningocele because the spinal cord is seen in the center and is mildly displaced towards the right side. So, with lateral meningocele and these cutaneous nodules, it could represent a case of neurofibromatosis type 1. I will like to correlate with the history of the patient, any previous imaging, and any family history.
what is the signal of lateral meningocele?
They are T2 hyperintense. Okay, these are
Okay,
solid. These are solid. These could represent neurofibromas. They are extra, yeah, they are solid looking. They are
okay.
not
What
T2
other
hyper.
features? What are the other features of this case?
Sorry?
What are the other features of this case?
Other than I've also seen some hyperintensities in the region of the spinal cord. These are the cord lesions. These could represent um, any transverse myelitis, any demyelination disease such as transverse myelitis. These are the another differential possibility could be of any infarct, but I would like to see it on the DWI images. Other
Okay,
differential possibilities less likely could be of a mass lesion.
your final diagnosis?
Um, I have also seen this extradural lesion also on the left side, and this could represent any schwannoma or neurofibroma. And this cutaneous lesion was worrisome for any cutaneous nodules such as neurofibroma.
Okay, if you found plexiform neurofibroma, serings, and subcutaneous lesions and intramuscular lesions, what should be your diagnosis? How do you diagnose NF1? Doctor. Hello?
Yeah, it could be NF1 because
Yes, what are the
NF1 who
diagnostic
have
criteria of FNF1?
cutaneous neurofibromas, any plexiform neurofibromas, schwannomas, and criteria of NF1, yeah, it has if the patient has family history, if the patient has a plexiform neurofibroma on imaging, that is diagnostic of NF1. And other than that, if the have multiple dumbbell-shaped neurofibromas coming out from the neural foraminal canal, like may more than one.
Okay, thank you. Thank you, sir. Okay, T1 here. Okay, some degenerative changes. You have to look at the cord. Okay, cord is very important because this patient is complaining of persistent
Backache.
back pain. Okay, so here, as you told, prevertebral is okay, vertebral some degenerative changes. Cord here is good, but if you go down, you can see the abnormal intramedullary abnormal signal intensity. So at this phase, I will correlate with the T2. Okay, and then ask for there is some discs here, but it is not related to our case, most important here. So here in the upper dorsal, okay, you can see here 1, 2, 3, 4, 5, 6, 7, 1, 2, 3, okay. So it is in the upper dorsal. We have to complete the study to involve the dorsal spine, okay. Dorsal spine, okay, syrinx is in itself, it is not pathology, but it is associated with other causes like Chiari
Pathology.
malformation like this, but here no Chiari malformation. You can see, but if you can look here, what is this? There is some scalloping, posterior scalloping of the spine, okay, here and here. And if you go through the image, you can see these lesions, okay, extending laterally, okay, here,
In the neural foraminal canal.
okay. So these are obliques for this neurofibromas. And if you go to the axial, as you asked it, okay, you can hold here an intramuscular lesion, okay, and this lesion extending through the canal, okay, and another subcutaneous lesion here, if you can see it, okay.
Yeah.
Okay, so you should think in F1. So in your management, you have to make uh, imaging of the whole spine, on the brain, searching for optic nerve gliomas, sphenoid wing dysplasia, multiple focal area of abnormal signal intensity or fascia in the brain. You can also search for any associated skeletal abnormalities, clinical examination for cafe Oli patches or axillary freckling, any
Cycling.
pseudoarthrosis, any associated spinal cord abnormality, spine abnormality. Okay. So, and also you
Yeah.
have to make genetic counseling and family screening for this patient, okay, and refer the patient to MDT, okay?
Okay.
Okay, this patient, okay, so here, plain radiograph simply, okay, the longest, you go, all this patient, old age, all this no significant abnormality, so you can, as you described, I'm looking lung fields are appears to be some reticulation, but not important, like to be the vessels.
Yeah.
This patient AB sitting, so and portable X-ray, so she didn't take full inspiration, so both lung fields appears to be small. However, cardiac shadow not so much enlarged, accepted the aortic shadow. Hilar shadow also accepted, no significant abnormality. Costophrenic angles appears to be clear. You have to look at soft tissue, and the most important thing, we have to look at the lung apices and retrocardiac region and diaphragm up and below. But if you go here, you can see this subtle abnormality. Maybe this Chilaiditi syndrome, or maybe an collection with gaseous content. So I have to correlate with the patient history if the patient has any constitutional symptoms or something like this. and I can go for ultrasound. Ultrasound first simple or CT scan, it will not differ so much more. But first in ultrasound, you have, okay, you have to comment on this structure. I can see the pancreas is seen well, no any gross pancreatic lesion. The visualized portion of the left liver hepatic lobe is seen normal with no any focal lesion or any coarsening of the parenchyma, and also right liver lobe visualized portions appears normal. Some periportal thickening seen here, and the portal vein is seen of average diameter and color filling, and then also here. But here in the up area or this area of the liver span, you can see gas containing lesion with dirty back shadowing. Okay, it is seen in segment 6. Okay, likely representing gas containing lesion. So I have to go urgently for CT scan. Okay, CT scan confirms the presence of the lesion with air surrounding the liver, and there is some air fluid level. And as you told, all the finding you told, so it is gas forming organism causing ruptured hepatic abscess, and urgent finding. Inform referring physician, urgent refer the patient. Avoid abbreviation in the exam, by the way. Urgent referral to interventional radiology team for drainage of the lesion and culture and sensitivity and further empirical antibiotic. Okay, the possible causes may be gas-forming organisms like Klebsiella, E. coli, or Pseudomonas. Okay, complication may be septicemia or septic emboli to the chest or septic emboli to the brain. So I have to check the general status of the patient. Okay, thank you so much. All the best, inshallah. Last candidate, candidate 6.
Yes, doctor, I'm here.
How are you?
Thank you very much. Yeah.
Okay, 30 years old male patient with RTA.
Sorry, what's the history? 6 year?
Motor 30 with motor vehicle accident.
Motor vehicle accident. Thank you. I can see a chest frontal radiograph of a 30-year-old male who had a recent accident. I'll just take a minute to go through the full image before I could say anything. I see there is a widened mediastinum and the trachea is shifted towards the right side. There is impression of apical capping on the left side, and also the left hemithorax is uniformly opacified with air bronchograms. I can't see any pneumothorax, and there is no effusion, and I'm looking for any rib fractures, which I'm unable to see any displaced fracture.
Okay, what are you thinking about with this patient?
So I'm thinking about aortic injury and a complicated like pneumonic contusions or aspirations and some complicated by left upper lobe collapse.
Okay.
So this is a serious emergency. I will request the team to I will ask for them a CT aortogram to look for aortic injury.
Okay, you can scroll.
Right. Okay. Yeah. Just
Scroll slowly.
yeah.
Slowly.
Let me actually take a bit control of it. Yes. So I'll just take a minute to go through the whole volume. This is a contrast enhanced aortic aortic phase. I think it's a bit lag while loading. I'll just
Scroll through your trackball or up and down arrows. Don't use the scroll bar. Just use your trackball or arrows, okay?
yeah. So using arrow. So yeah. Okay, arrows is there.
Wait. Take your time. Take your time. Scroll slowly and take your time.
Okay. Yeah. I noted that there is
Don't use the scroll bar, please.
Doctor, I'm happy to present if you just kindly scroll it for me a little bit, and then I'll be
Okay,
able to
I'll
pick up the
scroll. I'll
findings. Yeah.
scroll. Okay.
Yeah.
Wait. I'll scroll. Okay. I'm scrolling like this. Okay, one
Yeah.
by one. Okay.
Thank you very much. Okay, well, here I can see that there is dense hematoma around the in the mediastinal structures, specifically in the large around the large vessels. I can see there is aortic injury. If we're just a little bit up, just want to see examine properly the entry of the aortic injury. So at this location, after the subclavian, so I can see there is a bit of pseudoaneurysm. I would normally would see if there is any flap that would indicate that is yes. I think this is most in keeping with transection or some form of direct injury. I cannot see any dissection formed or yeah, here this is a pseudoaneurysm, likely traumatic in origin, and there is a hematoma around the mediastinal vessels. Will normally look the low pressure vessels, for example pulmonary artery. If there is any compression, this hematoma is dependent and sitting on the dependent
Okay,
spaces.
what's your management?
That would urgently will escalate to the cardiothoracic and the intervention radiologist if they can stent it. Because this is pseudoaneurysm, they can be stented. However, the discussion need to be taken place between cardiothoracic. So the priority will go with the intervention radiologist. I will speak to them first. So that patient also require resuscitation in the A&E department. So
Okay. This patient, 12 years old female patient with history of trauma with right hip pain.
So sorry, what's your age? I missed. What's the age
12.
of patient? Okay, 12 years. So frontal X-ray of pelvis of a 12-year-old patient who has a trauma. I would like to just go through the cortices if there is any fracture. I just noted that in the bilateral there is more space, like in the growth plates, widened physes. Normally I will just draw a line of Galen to look for any epiphyseal slippage, and I want to see the Shenton line if there is any cortical break. I'm unable to appreciate in this window settings. Normally I will adjust the whatever is possible to look for any fractures. I think I have a suspicion of bilateral So as the cortices are the epiphysis head is little smaller, and also it is bilateral, sclerosed. I think I would go with bilateral Perthes disease, because of this sclerosis. However, I think if I carefully draw the line.
Anything else? Ignore about the femoral heads.
Right. So anything else in the lesser trochanter on the right side, that's also fuzzy, so that it is likely to be an avulsion fracture, and I can't see any avulsion on the right hand side.
She's a female patient. She's not playing football.
Okay.
No avulsion fracture.
Yeah, so it can be a fracture on the superior pubic ramus. Difficult to see. There are some cortical fragments in the inferior aspect of his tabulum, so that could be some avulsions there. But
Can you tell me how to approach pelvic radiograph, please?
so the pelvic radiograph, this patient, I have to just look for the.
And can you raise your voice, please?
Okay, yeah.
Because you.
So here, as I have want to see the bones first, as per history of trauma. So the bones, I'm looking for the cortices, and here, for example, I have noted that there are bone fragments in the area which is projected inferior to acetabulum and the superior pubic ramus. So there is a possibility of a fracture, and apart from that, there is some density sitting right side of the bone, so that could be a pelvic hematoma secondary to this fracture.
Okay, I'll give you another image. Maybe clear. Can you look?
Okay, this is another image.
Same patient, but another view.
Okay, so another view. So even in this patient, I am suspecting. So even in this patient, I am suspecting the injury to the acetabulum and the superior pubic ramus.
What's your diagnosis?
So the diagnosis in motor vehicle accident. So normally I would consider
no motor vehicle accident. So previous patient motor vehicle accident.
All right. So this is can be an aneurysmal bone cyst in this age. This is very could be a primary bone tumor. However,
did you describe any bone lesion? Just you are thinking, but you didn't describe anything.
So this is a bone lesion. This is a lytic lesion which is involving the upper superior pubic ramus and extending towards the.
Now we are starting to talk well, but all the previous I didn't hear from you anything. Just you are trying to go through fracture, and now you should describe well. Describe what are you seeing.
Okay, yeah, this lytic lesion, which is involving the superior pubic ramus and extending towards the acetabulum.
Which superior pubic ramus? Right.
The right side, the right one.
Okay, you have to mention right.
Yeah, and then it has. I cannot see the zone of transition. To me, it appears. I think there is a cortical involvement, and the soft tissue is involved. So
okay, what would you do next for this patient?
So I think the patient need an MRI to look for the further fracturization.
Scroll through the MRI. Yes, one by one.
Yeah. Okay, so in this T1 weighted image, I see that the lesion, the lytic lesion, has multiseptated, well corticated lesion, which is centered at the superior pubic ramus. There are just want to look for any chondromatous chondroid matrix, which could be another possibility. Normally, I will also correlate the T2 images as well to look to correct in the other images. I can see there are some layering within the cysts within it. So the ABC is one of my differentials. Normally, I would go through all of the images to look for other
Which sequence do you
features.
need to see?
I want to see T2 and with contrast.
T2 weighted
T1 with
image.
contrast and T2. Yeah, so in this T2, I can see clear the layering of the fluid levels, and that is one of the features which indicate this is an aneurysmal bone cyst.
Okay, what other differential could be this lesion?
So the differentials can be telangiectatic osteosarcoma, or
Okay.
yeah, and the
Okay, what will be the management?
so that need referral to the sarcoma pathway, 2-week wait, and they need to be referred to the orthopedic surgeons. That lesion need to be curetaged and filled. Maybe the certain bone resection need to be performed, and a bone graft after that.
Okay, thank you.
So
Thank you.
yeah.
Thank you so much. Okay, here in the plane radiograph, okay, you can see this expansile lytic lesion involving the right superior pubic ramus acetabulum and then extending to the iliac bone, and there is associated soft tissue seen here. Okay, this one. First of all, to approach the pelvis, you have to go through rings. Okay, outer ring. Okay, go like this. Then inner ring like this. If you go to the inner ring, you will see the abnormality very well. Okay, and there is Shenton's lines bilateral. Okay, which is disrupted here on the right side. I will clear the drawing. Okay, and also this acetabular ring, which is small here on the right side. And also, most important areas, you can look at the arcs of the sacrum and look at the distal sacrum, maybe some chordoma or chondrosarcoma here. Okay, so it is very important to go through the pelvis like this. And then, so if you go through this, you will find the lesion here. You have to describe it is an ill-defined expansile lytic lesion seen through the right superior stabulum, right superior pubic ramus, and extending the right iliac bone, associated with soft tissue swelling seen indenting the urinary bladder. No so much soft tissue component along the outer surface. No appreciated internal calcification or chondroid matrix. In my routine practice, I will check the other orthogonal view, which confirms the presence of the same lesion. No appreciated pathological fractures. The hip joints on both sides appears to be preserved. No any dislocation or any sclerosis of the femoral heads. To take, so I'm suspecting like this. Maybe aneurysmal bone cyst, or maybe aggressive lesion like telangiectatic osteosarcoma or giant cell tumor, but less likely in this age group. Okay, and maybe also fibrous dysplasia. So I will take this patient further to MRI. MRI confirms the presence of the lesion, which may be multiple septations and layering, and then So, and so much soft tissue component surrounding it, and the joint is preserved. Fluid level on the T2 sequence, and they all correlate with the corona like this. Okay, so it is likely to be aneurysmal bone cyst, less likely to be malignant lesion. I will send to orthopedic oncology MDT for any for further curettage and grafting for the lesion. Okay.
Yeah, thank
You
you.
need more practice, I think. This case, okay, motor vehicle accident on the young age patient, mediastinal widening, left apical capping, veiling of the left lung field. We couldn't appreciate here the aortic knuckle or the descending aorta well, so we are suspecting, and there is mediastinal shifting to the right side. We couldn't appreciate any rib fracture, any scapular fracture, upper abdominal cuts are remarkable. So this is an emergent case. I'm suspecting aortic injury. Okay, urgent CT aortogram, and CT aortogram you can find here the presence of traumatic pseudo aneurysm through the pseudo aneurysm is the aorta. Okay, and the intima, and there is injury, and there is formation of the aneurysm from the layer of the outer layer of the aorta. So it is a pseudoaneurysm with large mediastinal and hematoma and left hemo pleural effusion with hyperdensity, likely to be blood. I will check the lung window for any associated pneumothorax or any lung injury, and urgent refers the patient to cardiothoracic team for surgical management. Okay, this is safety case. Okay, thank you all candidates. Anyone have any question? We can answer any question. Oh.